Sorry about that. Okay. So again, welcome everyone and welcome to our Project Echo today. And again, my name is Melissa Moon. So on our agenda for today, some introductions and announcements. The discussion today is hepatitis C in adolescents with a prevalence and impact on overall health, and Dr. Alfaro Cruz will be presenting on that. Following that, we will move into our case presentations and a time for question and answers, and then some closing remarks. Now, to just a few quick reminders, we need everyone to take a minute to register with our accrediting body, the Southeast AETC registration, and that's required for CE and grants. Y- Um, and then you can also access numerous additional resources from this link as well. You can either use the QR code pictured here on the slide, or you can use the website link that will be posted in the chat. So I'll give everyone a couple of minutes to register if they've not already done so. Okay, so we will move forward. So some announcements. If you don't care to introduce yourself in the chat, give your name, your role, your organization, and if this is your first Echo session. If you do have any Zoom tech issues, please private message Kimber and she can help get that fixed for you. We're seeing several introductions. I was trying to see if we saw anyone who said this was their first session yet. And again, if you needed that link for the CE credit, Kimber did post that in the chat as well. Okay. So I will hand this off to Dr. Alfaro Cruz. If you don't care, just to tell me next slide and I will move the slides for you.
Absolutely. Can you hear me? Okay, perfect. Good afternoon, everyone. We are here to talk about today about hepatitis C in adolescents, prevalence and impact on their overall health. Next slide, please. I have no financial disclosures or conflicts of interest to report. Next slide, please. And so by the end of this talk, I want you guys to be able to establish the current prevalence of Hep C in adolescent population, identify some of the risk factors in this population that may lead to a Hep C infection, recognize what are the most common screening factors in adolescents, identify the health impact that derive from a chronic Hep C infection, and recognize the importance of STD counseling in high-risk populations as well. Next slide, please. So let's talk a little bit about Hep C in infants and adolescents. And so the prevalence of Hep C infections in children and adolescents has been reported to vary from country to country. And so we know that worldwide we're thinking about it could be 0.5% to 7%. Now here in the US and Europe, we're talking about a prevalence of 0.05% to 0.36%. And in developing countries, it can go up to between 1.8 4.8% to 5.8%. Now, it is important to mention that most of the pediatric research that we have focuses on high-risk populations. So we're talking about homeless, infected, homeless adolescents or homeless children who are infected with HIV, children that usually will live in an endemic regions or in drug rehabilitation centers. So that's why potentially the numbers can change from country to country because all these studies are based on, especially in those developing countries in endemic areas. Now, mother to infant transmission during the perinatal period has emerged as the most common mode of acquisition of infection in children. Up to 60% of the cases, not only in the US but worldwide, are thought to be due to mother to or thought to be secondary to perinatal transmission. Now, the prevalence among children is higher in adolescents, likely given the cumulative exposure of risk factors over time. So, when we talked about mother to infant transmission during the perinatal period, we're talking about incidence. But when we're talking about which group tends to be more affected or where do we tend to see it more, it's usually going to be adolescents between ages 12 to 19, and then usually 18 to 29 have been reported to be the highest. Now, and this is, as we were saying, usually can be a cumulative of risk factors over time. And the older the adolescent, the higher the Hep C prevalence that we see. Next slide, please. Intravenous drug abuse is significantly and increasingly common route of Hep C infection in adolescents and young adults. And this actually makes sense because it's mirroring the IV drug abuse epidemic that we are seeing, especially in the Appalachia area or like Northeast Tennessee, where the opioid crisis has been increasing throughout the years. Now, you can see here, there's kind of recent studies where have shown that there has been a 364% increase in Hep C infection among people 12 to 29 years of age. And of course, in mostly of these studies are coming from the Appalachia region, which is important to mention that not only because you think he's a 12, a 13-year-old, or a 14-year-old, you have to ask about substance abuse. We are seeing it more and more frequent now. And so it's something that we have to be mindful about this. Next slide, please. Now, when we talk about screening in children and adolescents, we usually try to look at the clinical picture first. So, if we have any children or any adolescents with clinical evidence of hepatitis, increased AST and ALT levels, those are the kids that we want to screen for hepatitis. All children born to a mother living with Hep C, including those siblings of a child with Hep C from vertical transmission, if they're born from the same birthing parent, you have to screen them. International adoptees and refugees. I think we have mentioned this in the past, where our prenatal screenings differ from other screenings in the world. Developing countries usually or may not tend to screen so much for Hep C as they're usually not seeing commonly or they're not thinking about it, right? So it's important that anytime you have an international adoptee or refugee, you think about screening for Hep C as part of their baseline. Children and adolescents living with HIV, because there can be a co-infection and it's important to screen for that. All victims of sexual assault should be screening. And individuals who are actively using drugs must be definitely be in the risk population and needs to be screened. Next slide, please. Now, when we talk about screening, and this is kind of more oriented to adolescents, children and adolescents with intrafamilial exposure should be. And sometimes they can be related with cases of sexual abuse or incest that we tend to find in certain areas. Adolescents that are incarcerated in correctional institutions, especially those who practice in tattooing or body piercing in unregulated settings, and we see it a lot in correctional institutions, they should be screened for Hep C. Adolescents who have injected illicit drugs in the recent and remote past, even if it's only one time, and they don't consider themselves to be drug users or like they said, oh, I just do it for fun one time and has It's important to give counseling to adolescents, saying it doesn't matter if it's one time or two times, the risk is there. But especially when we ask questions about, are you using drugs or have you used drugs in the past, it's very important to mention that, because most of them will think more about the present and not if they have done it in the past. Next slide, please. As to the US right now, we know that the United States Preventative Service Task Force is recommended screening for Hep C in all adults aged between 18 and 79 years, including pregnant women. Now, as we were saying, the research for the pediatric population varies, and we really don't have a specific of like, yes, you need to be screened at least one time in your life, like they do it in the adult population. So that's where it's important to think about the screening recommendations or what clinical presentation or social presentation may lead you to actually screen for Hep C. Now, in the case of the pregnant population, it's a little bit different because all pregnant individuals, even if they're under 18, should also be considered for screening due to rising Hep C prevalence if women of childbearing age and infant born to infected mother that we're seeing. Especially if it's associated with other risk factors like use of IV drugs, tattooing, being in correctional centers, and things like that. Next slide, please. Now, right now, as you all know, we follow up the Tennessee Department of Health recommendations. Especially, we're talking, and we have mentioned this in the past too. If a child is between 2 and 6 months, they get a Hep C PCR RNA viral test. If they are between 7 to 17 months who have not been previously tested, Hep C PCR RNA will be the test of choice for diagnosis. Now, if they are more than 18 months of age or 18 months and have not been previously tested, we usually are going to send the Hep C antibody test with a reflex to a PCR RNA in order to diagnose that patient to see if they have Hep C or not. Next slide, please. So in this slide here, it kind of gives us a little bit more the idea of what do we do in adolescence, right? I think it's kind of more straightforward if we have a patient that it's under 18 months of age. It's an infant, it's a little baby, so it's kind of more straightforward. But when we're talking about adolescence, first we have to obtain kind of a clinical picture and a social picture. Are there risk factors in these adolescents? Are they using IV drugs? Do they have multiple sexual partners? Are they engaging in men having sexual relationships with men? And so in this case, you will actually send antibody testing. Usually, if it's negative, you repeat the antibody test when there is a new ongoing risk factor for Hep C infection, or there is concern that there can be a Hep C infection like elevated AST or ALT levels. Now, if it's positive, that's when automatically the test should reflect into a PCR RNA to look for the viral load. If that is negative, then we know that it could potentially be a false positive antibody test or a resolved Hep C infection. The patient could probably had been infected with Hep C, had a spontaneous resolution of the infection, and then they will always test positive for the antibody. So that will come with the explanation of if you had a Hep C infection in the past and you resolved it without treatment or required treatment, your antibodies will always be positive. So this would not be the test of choice to diagnose for an active Hep C infection. Now, what happens if that viral PCR RNA is positive? So in that case, we have an active Hep C infection. We need to provide counseling and we need to get social work involvement if needed, especially in those who are having high risk conducts that may lead to potentially spread the disease or not able to treat the disease. Now, following that, we'll talk with the patient about obtaining further workup, including genotype. Usually, now with the direct acting antivirals, we can actually treat all genotypes without any issues, but we'll have to get it for like insurance purposes as well. Get baseline labs, of course. It will include liver enzymes, CMP, a complete metabolic workup, to look at the kidney function, liver function, and then initiate therapy with direct acting antivirals. The goal is not to delay treatment at all because we know especially how effective the medications are, that if we can treat it, we can cure it and we can eradicate it. Most of the time, we recommend, especially with those who have high risk of social situations going on, to follow up with them. Try even to do telehealth every 4 weeks in order to make sure they're taking the medication, screen for any side effects, and help facilitate treatment. We will check a viral load 12 weeks after finishing the last dose of medication. Next slide, please. Now, something that we have to take into account when we're talking about Hep C with adolescents is you have to communicate to the patients that the screening is voluntary, and explaining to them that this is not have to be enforced if they don't want to do it, and they have to understand that they have to accept the screening and understanding what the screening entitles for and what it will be planned and what will happen if the screening tests positive. Informing them about Hep C infection, how it can and cannot be acquired, the meaning of positive and negative results, and the benefits and harms of treatment. Even though they are young, even though they may not have the entire capability of understand what's going on, it's important to have these discussions with them, especially those children who practices other or who are related to have any other medical conditions that can actually worsen liver disease like fatty liver or autoimmune conditions. And then providing the patients the opportunity to ask questions and to decline screening, it is acceptable. Especially in adolescent population, when a lot of these discussions are occurring one-to-one, it's important to them to let them know that privacy and confidentiality is established. So it's something that they should know, and they should have a say in treatment, screening, and evaluation. Next slide, please. Now, we do have limitations, and I think most of that has been taken by the point that we really don't have that many studies or protocols that have looked specifically at epidemiology of Hep C infection in adolescents, as well as the effectiveness of direct-acting antiviral regimens. Most of the time, most of the data comes from cases report or comes from the adult data that we get. And so we try to extrapolate that. So the goal will be in the future to obtain more data that is just pertinent to these adolescent populations so we can focus more our treatment, diagnosis, and so on for these patient population. Next slide, please. So let's talk a little bit about their impact in health. And we know that Hep C is the leading cause of chronic liver disease with no preventable vaccine. So unfortunately, and it's something that it's important to mention to parents as well, we don't have a Hep C. Compared to Hep B and Hep A, we do have vaccines for those. But for Hep C, it's one of those that we don't have it. And liver disease, due to chronic Hep C infection, generally progresses very slow in children. And cirrhosis and liver cancer occurs very infrequently in this population. Now, Bortolotti and company suggested that there can be three patterns of infections. One, it can be early clearance of viremia at a young age. They have a spontaneous resolution, especially those babies that tested positive for a Hep C PCR RNA. And by the time they get 3, we retest again, and there's nothing there. So we're talking about spontaneous resolution. The second could be asymptomatic viremia, persistent with normal or abnormal ALT and AST, which can happen. And then the third pattern could be early progression to cirrhosis in a very minority of patients. And when we're talking about these symptoms, some studies have actually recorded that out of 44 children that they were included in a retrospective multi-study center, only 4 had significant fibrosis after a mean of 8 years of infection. And after an average of 5 years, about 70% of those children who had fibrosis had regression or no progression to cirrhosis anymore. So that is kind of very important to know. And so it's one of the things that give us the chance to treat these kids to prevent into going into chronic liver disease. Now, Hepatomegaly, it's the most common manifestation that can be found. And when present, it can be associated with elevated transaminases levels. This is not going to be all the time, but it's usually something that most commonly see. Extrahepatic manifestations like portal hypertension, it's more common in adults, but we don't tend to see it, or it's very rare to see it in children. Even those who have develop acute liver failure from Hep C, it's a very rare number to see, and it's usually will resolve on its own. Initial assessment, it's going to be very important with children with chronic Hep C infection, and this will include to exclude other causes of liver disease, especially when we're talking about autoimmune causes, genetic etiologies, other viral infections, Hep B, Hep A, cytomegalovirus, Epstein-Barr virus. You have to assess the disease of the severity, and that will help us in order to say if this patient is at risk of chronic liver disease, of cirrhosis, and so on, and any detection of extrahepatic manifestations. Although it's very rare to see those, it is important to detect them and screen for them, as in some few cases, they can present like that. Next slide, please. So the disease severity is usually assessed via routine blood work and physical examination, as well as the use of non-invasive modalities. We have elastography, we have imaging that we can use, serum fibrosis marker, and it's recommended with adolescents with chronic Hep C infection. It is important to kind of get a detailed information about when possible this kid could have been infected for Hep C. I've had few cases where they were 14, 15 years old. Their mom had Hep C, and that's how they got transmitted. And because they had presented with no symptoms, no lab workup or anything, their diagnosis was late. And so it is important to get kind of an idea, or clinically, when could they have been exposed. Now, children with cirrhosis, should undergo a hepatocellular carcinoma surveillance and endoscopic surveillance for Barrett's per standard recommendation. That applies to every adolescent. If they do present with cirrhosis, we are going to do it. We're going to check alpha fetoproteins. They're going to get their scopes yearly in order to assess for any variants, because what we want to prevent it's complications that may lead to increased morbidity and mortality. Next slide, please. Hepatotoxic drugs should be used with caution in children with chronic Hep C infections after assessment of potential risk versus benefit or treatments. In children, usually, or in adolescents, we don't tend to see as many medications that they take as many medications compared to adults. But we have to be mindful about which medications are we going to use, especially if we're using seizure medications, proton pump inhibitors, or things that can actually cause more liver damage. Anticipatory guidance about potential risk of alcohol intake, especially in the adolescent population. It's important. It's important in order to have, as they may think, oh, it's just one, I just do it for fun, I just do it kind of with my friends, but it's important to talk about the cumulative risk that can lead to severe or worsened liver disease. Next slide, please. And due to this low rate of fibrosis, as we were talking, there are few, if any, established bona fide risk factors for disease progression. We really cannot tell which kid or which adolescent will progress into cirrhosis, into liver failure as they get older, because we really don't have enough of the data or enough of those risk factors to actually say, yes, this is the kid that's going to progress. Now, as we have said, we have mentioned before, development of advanced or chronic liver disease or severe liver disease in children is very infrequent, and to more than 30 years of infection. So that's when our adolescents who get into adulthood start showing more signs and symptoms, because it's very slow and it can take up to 30 years to actually show. Next slide, please. Now, in children with cirrhosis, we talked about it. We usually will do a liver ultrasound with or without alpha fetoprotein testing every 6 months in order to provide surveillance for hepatocellular carcinoma. A baseline endoscopy is also advisable in those that usually will have positive for barracks. We usually scope them every year, if not every 3 years, as a screening method. After successful antiviral therapy, the risk for cirrhosis complications decreases substantially, and we also talk to them about how can that have an impact in their health, regarding like screening, unnecessary procedures, if we can actually treat it. Next slide, please. Maintain a healthy body weight will actually be an important discussion. We are seeing an increase in obesity rates and overweight rates in our adolescent population, and it's important to explain them that maintaining a healthy weight will actually prevent issues like fatty liver that can contribute to worsening liver disease. Commonly used medications such antimicrobials and antiepileptic or cardiovascular agents should be dosed per standard recommendations, as we were talking. And NSAIDs and aspirin should be avoided if possible, because there can also be an association with increased bleeding, especially if they have liver disease. Tylenol is a safe and effective analgesic for children with chronic Hep C infection when dosed per package insert recommendations. So we usually are mindful to talk to them about the preference of using Tylenol instead of Motrin or NSAIDs or aspirin if you have chronic liver disease. Next slide, please. So when we said, we talk about the clinical trial data that has evaluated some of the direct-acting antibody regimens in children and adolescents, and they have allowed expansive use of these safe, well-tolerated. As you know, we are using them now in children that are 3 years and old or older, because we have seen the effectiveness. Now, treatment of children as young as 12 years is predicted to be very cost-effective with current approved of DAA regimens. The incremental cost utility ratio for early versus delayed DA therapy was less than 12,000 per quality adjusted life year gain. So treatment during early childhood is very cost effective, and delaying therapy until early adulthood may result in increased lifetime risk of complication of late stage liver disease. So this is something that I want to take for you guys to take home. Do not delay treatment. Treat, treat, treat. Do not wait. If you have a diagnosis of Hep C, if the patient doesn't have cirrhosis and you have a diagnosis, don't delay treatment. Start treatment right away, because those 3 or 4 or 5 months that you're waiting for that patient to be seen by a specialist, that patient can actually be treated and cured, and you're actually making a significant impact in his overall health and in the lifetime risk of complications because of advanced liver disease. Next slide, please. Now, when we finish, right, we talk to them, we counsel them, we explain them that reinfection is possible, that treatment does not prevent reinfection, that they can still get it again and they will require treatment again, that Hep C antibodies will always be positive no matter what, and that the Hep C PCR RNA will be the test of choice for all future testing in clients with a history of Hep C. Next slide, please. We also discuss with them to recognize the dangers of drug use, especially if we think that their Hep C was secondary to the use of IV drugs. We explain them that those are risk factors and those are behaviors that will endanger him to get reinfected. The importance of talking about safe sex practices, to avoid sharing needles, to get tattoos and piercings in places that are regulated and that are safe, to not share any personal items that may carry blood, even toothbrushes, razors, nail clippers, and that so far we don't have a vaccine that prevents Hep C. And therefore, the only things that we can do is talking to them about avoiding these risky behaviors that may lead to a reinfection again. Next slide, please. Any questions before we move on to our case presentation? And one of the things that I want to add is we really follow very closely kids who have Hep C infection, and especially if they're presenting with obesity, because fatty liver disease can actually fatty liver disease is considered the second most common cause, or the first common cause of non-related to alcohol, of liver disease. So it is very important that you provide counseling to any adolescent that has Hep C and it's obese. Even if they don't have Hep C, we try to prevent counseling of healthy eating and maintaining a healthy weight because this has been associated with worsening liver disease, especially as they get into adulthood. Thank you.
Thank you. Now, if anyone has any questions, you can come off mute or you can put them in the chat. So we'll give it just a few seconds to see. Doing the echo pause as we call it. Okay. If you all think of questions, you can always put them in the chat. We'll have time at the end to also answer questions. So we will move forward with our case presentations. So Annie, we'll let you start.
Thank you. So case number 1